of the core systemic historical issues in how we treat Black and brown patients in healthcare, how we offer them healthcare, is associated with the very, very, very long endemic history of inequity in healthcare research. So if you think about what forms our basis of knowledge and progress in healthcare, it's all this like decades and decades of research. And if you looked at those studies and found out who they did those studies on, you're like, oh, man, 98% of the patients were white, white females. And the conclusions aren't necessarily generalizable to a different socioeconomic or genetic demographic. And I think that's really important for everybody to understand, that when we're even beginning to address a conversation about racial and ethnic inequalities in the way we take care of women in the United States, we're standing on a mountain of data that doesn't necessarily apply to the treatment we give to this population.
We know for sure as scientists, clinicians, and researchers that Black and brown bodies are usually not represented in a lot of major studies to the degree that is representative of the population, which then makes us question the generalizability to these populations. But the other thing to that, and sort of my new catchphrase, is that Black is a big box. Like, there's so much diversity within the color or the race of Black. So it's very important that we're paying attention to the fact that these categories that we create are also huge boxes that have diversity even within them. But when we're talking about the lack of diversity in research, I think it's very important for us to recognize why that exists. And there's two things that sort of play a big role on that. For one, we have to say their names. A lot of this is historical. Some Black and brown people are really not they're not trusting the medical system. They don't trust their doctors. They don't trust hospitals. And that stems from decades, if not centuries, of just being mistreated. I mean, we have to call their names: Lucy, Anarcha, Betsy. These are women who are operated on without their consent, without pain medication, even when anesthesia was widely used. I mean, we have to call it out. It's the Tuskegee Project, where we know that there was men who were followed just to see like what would be the natural progression of syphilis, and how that creates extreme mistrust in people even accessing medical care. But even bigger than that, it really, when Blacks are really starting to make a stride after slavery and Jim Crow, it really, turned things backwards for us and really reverted a lot of our progress.
I'll share an anecdote with you, Dr. Bennett. When I was a resident, so a lot of Black women don't trust their doctors. But the anecdote I'll share with you goes all the way back to 1996 or 7. So I was a resident at Holy Cross. I was a resident at George Washington University, and I was doing a rotation at a hospital called Holy Cross Hospital in Maryland. And my chief resident was a doctor named Leslie Nurse. Interesting, Dr. Nurse. She was a Black woman, probably one of the kindest, most friendly, knowledgeable. She was the administrative chief resident. And if any of you have done an OBGYN residency, the person who becomes the administrative chief resident is typically thought of as the best. So I was on this rotation with Dr. Nurse, and her and I went into a room to see a patient, and the patient, of course, instinctively, and even though Dr. Nurse was clearly leading the conversation, I was standing there with my arms folded. And she called her nurse, I think maybe because it said nurse on her badge. But when Leslie explained to her that she was the chief doctor on the team, she said, the patient said to her, and I'll never forget this, "I don't want a Black doctor taking care of me." So there's precedent for everything we're discussing. This is all very real. If you don't trust your doctors, then how are you going to get good health care? Because our patients are our healthcare partners. They're partners in getting better and preventing illness. All right, so I digressed slightly from what I really wanted to discuss and get Dr. Bennett's expertise on, were issues associated with morbidity and mortality in maternal health care.
But you know what that makes me think of? It has to be our responsibility to gain their trust.
That's right.
We can't just say, oh, she's not taking her medications because she's non-compliant. She's non-compliant. It's sort of like a write-off. You're like, I told her, she's not doing it. She's just non-compliant. I think we have to take the next step. The onus has to be on us. It is our responsibility to gain her trust. It is our responsibility to explain it to her in terms that resonates with her, that's specific to her culture, that's going to make her understand why it's important to take her medications. It's our responsibility to get her over the hump of the mistrust. That's on us. Yeah, I'm just glad that you both mentioned and recognized that you're taking care of a lot of minority women and realizing that, hey, there's a mistrust here. But the question is, what are you going to do about it? And I think this podcast is a part of figuring out what are you going to do about it, because it's our responsibility.